My name's Tara Melfi. I'm the program coordinator for the HIV Primary Care and Prevention Center of Excellence within the Clinical Education Initiative. Today, I'm joined by Dr. Asa Radix, one of the lead authors of the New York State Clinical Guidelines on Protocol for Rapid ART Initiation. These guidelines were recently updated in January 2020 by the Medical Care Criteria Committee from the New York State Department AIDS Institute. So thank you for joining me today, Dr. Radix.
Hello. It's nice to be here.
Great, so let's just jump in and talk about these new guidelines. Can you first explain what rapid initiation of ART is?
Okay, so rapid initiation of ART actually refers to starting ART on the same day, or at least within 72 hours of a confirmed HIV diagnosis, or having a high suspicion that someone is HIV positive based on a positive screening test. And I should say this is new because in the past we've always told people, we're doing a screening test. We still have to wait for a confirmatory test. So we'll do the confirmatory test and then, you'll come back within a few days, sometimes a few weeks to get the result. And that's the point where the discussion about starting medication happens.
Great. And what are some key examples of how the timing of initiation of ART is effective?
So, I should just go back and say, like, one of the things that we know is that there are many people living in the United States who are unaware of their HIV diagnosis. So, they say only around 86% of people living with HIV are aware. And actually only about 51% or so of people living with HIV achieve viral load suppression, which means that the amount of virus is not detected in blood tests. So, that's not a very good statistic. And one of the things that we've seen is that for people who are started on ART as soon as possible, there is more likelihood that they're going to start and that they will achieve viral load suppression. I mean, right now, what has happened, I should say, in the past is, when you tell people you have a preliminary, screening test that's positive, and we're going to do these follow-up tests, and you're going to come back, and we're going to discuss these tests, sometimes people just don't come back. And that's really one of the factors that leads to people not being able to achieve viral load suppression because they weren't started on medications in the first place. So this really has really changed things so much because of the really great results that we're seeing.
Great, thank you. And so going back to the updated guidelines from the Medical Care Criteria Committee, what are the main recommendations and key points that you'd like to share for New York State clinicians on these updated guidelines?
Right, so the main thing, as I said, is that you no longer have to wait to get a confirmatory test result, that if you have a positive screening test, it's really completely okay to go ahead and initiate ART that day, or again, within 72 hours. And so I think that's the main thing. The second is that you don't need to wait for the test results to come back. For example, test results on, the renal function, liver function, STI results. You don't need to wait for any of those. The medications we use currently are incredibly safe. And, even if it turns out that someone had a false positive screening test, you're not doing anything really untoward by having them on HIV medication for a day or two until you get that confirmatory result back. So again, that it's effective and safe, and also that we're using regimens that have very low side effect profiles. So it is a change, but it's a very positive change. So I think those are the main key points, really, starting as soon as possible, that it's effective and that it's safe.
Okay, great. And can you break down kind of the protocol with rapid initiation of ART? I know it includes some education of the patients and then follow-up afterwards and so forth.
Yeah, the New York State protocol, if you go to the website, goes through like the whole chain of things that you need to do. So really it's step by step for providers. It leaves nothing out. So, I mean, as you said, it starts off by giving some tips on counseling and education for patients. I mean, understanding that someone's just had a positive result and you're going from giving them this positive, reactive test result to talking about medications, sometimes in a very short period of time. So, it's useful to have the tips available. So, talking to people about, what is HIV, some information about HIV transmission, information about using condoms, especially in those first few weeks before the viral load has started to come down. Talking to folks about the need for adherence and bringing up the topic of ART and the reasons why it's really important to start ART as soon as possible, right? So not only for the person's health and well-being, but also to prevent ongoing transmission of HIV. So yes, I mean, we always prioritize issues around the benefits to the immune system. It's also important to assess psychosocial barriers that might exist. So, talking to people about, issues of homelessness or substance use, issues with insurance, not because it's going to prevent you from starting ART, but so that you can go ahead and offer resources as soon as possible. So those are all of those items. It also discusses the baseline tests that you need to do. Now, the baseline tests are really the same as the tests that we do in general, but it's really, really important to make sure that a baseline genotype is done before you start on ART, just in case the person isn't responding to medication. You can have a genotype in front of you to make sure that, at a later point in time, to make sure that they're on an optimal regimen. It covers also the different types of medications that you should be thinking about starting. And probably most important, talks about resources to help people get the ART. So whether it's getting on insurance or accessing medications through, going on to Medicaid quickly, or the new plan from New York State for folks who are uninsured, or copay cards for people who have insurance. I mean, I think these are all, it might seem obvious, but I think in the moment, providers sometimes forget about all the different things that need to happen in that first visit.
Yeah, definitely. And we'll have those steps. It's a nice graph. It's nice and purple and everything step by step. We'll have that below so everyone can see what was just talked about. So that's great. Thank you. And just to wrap up, you noted the specific regimens. So could you kind of describe the preferred rapid ART regimens?
So first, really the preferred regimens for rapid ART are really focusing on a select group of medications that, first of all, are highly effective. I think that's the most important thing to tell patients. Also, that these are medications that have a high barrier to resistance, and they're also incredibly well tolerated. So, the reason for this is that we want to obviously give people medications that we can start without having the results back from, as I said, things from renal function or liver function or, genetic tests that we do, for example, for abacavir. We don't have any of those available, so you can't use certain medications at all. So the preferred regimens include really the integrase inhibitors, either bictegravir or dolutegravir, and also combining that with an NRTI. So usually, emtricitabine plus TAF or tenofovir alafenamide. And usually, these are regimens, again, that are very well tolerated. The only caveat I would say is that if you have a person in front of you who's pregnant or, at high risk for pregnancy, perhaps these are things that you want to determine ahead of time, because you can't use dolutegravir and bictegravir in the first trimester of pregnancy. So you do want to rule that out, but otherwise they're incredibly safe. So, I mean, there are many, you'll see when you look at the guidelines that they also have regimens for people who you're concerned about resistance. For example, they may have been on antiretrovirals, for example, PEP or PrEP, and since the last negative test, and you might have to put a bit more thought into regimens. But for 99% of people, you're going to be able to use the first line regimen that's listed. As I said, either bictegravir or dolutegravir base regimen.
Great. So yeah, that was a great overview of the updated rapid ART guidelines. So thank you very much, Dr. Radix, for taking the time to speak to me today.
Okay, thank you.
So if anyone watching this video would like to learn more about the updated rapid ART guidelines, there'll be a link available below. And also, if you're looking for continuing education credit for CME, CNE, or CPE, here at the Clinical Education Initiative, we've developed a new course with Dr. Radix on these guidelines called Rapid ART Protocol for Initiation, which will also be found below. So great. Thank you, Dr. Radix, and stay safe.
Okay, thank you.